I thank the AIOC Scientific Committee and my panel here for giving me this opportunity to present something which really interests all of us, and I'll try to show the scientific angle to it. And we know that with the advent and with the discovery of anti-VEGF, this has been a game changer for treatment of age-related macular degeneration. And from 2006 onwards, when we first started the anti-VEGF therapy, to the present times, we are still striving for new therapeutic targets, increased durability of treatment, reduced treatment burden, and improved anatomical outcomes. So with anti-VEGF, first time Anchor, Marina, Harbor, and VEGF Trap, all these View 1, View 2 studies, we first started talking of improvement in visual acuity. But down the line, when we came up with this trial, 7 years down the line of use of anti-VEGF, what happened? So even after 7 years, the patients who were enrolled in Marina or Anchor, which were the earliest studies of anti-VEGF, we saw that almost 68% after 7 years also had active exudation, 46% was still receiving ongoing anti-VEGF treatment, and the moment they were out of the clinical trials, almost 1/3 declined by 15 letters. So neovascular AMD is a long-term disease, and it requires consistent treatment to maintain visual outcomes. If the suspension of treatment is done, within the first year, 41% will have recurrence, and after 5 years, almost 80% cases will recur. And the eyes which resume treatment after having a recurrence have a permanent vision loss of more than 3 to 5 letters. So for treatment of neovascular AMD, the most important thing is prompt diagnosis, treatment, proactive individualized treatment, and continuous long-term treatment in spite of the optimized burden that increases. And this is quite significant not only for the patient, but also for the caregiver who has to bring in the patient every month for OCTs and checkup and injections. And for the society, it increases the cost of treatment and durability of the chosen molecule. These are few questions we have to ask ourselves and answer to the patient all the time. So it is a challenge to maintain the neovascular AMD treatment efficacy while reducing the clinical visits. Aflibercept, with its binding capacity of almost 100 times that of ranibizumab, as well as the fact that it inhibits VEGF as well as the PGF dimer, it definitely translates into a longer duration of action and reduces the frequency of injections and visits. So to test this hypothesis, we had the View 1 and View 2 study, which was a large phase 3 study of more than 1,200 treatment-naive patients, 300 patients in 4 arms, where they tested 0.5 milligram of 4 weekly, 2 milligram 4 weekly, 0.5 milligram of 4 weekly, and 2 milligram of 8 weekly Aflibercept. So these were the 4 arms which were seen, and the results were evaluated at 52 weeks as well as 96 weeks. So this is a graph that I have taken from the study. It has shown us that the patients who received any of these 4 arms, they did gain significantly where the visual acuity was concerned, but the 8 weekly arm did not lag behind in the gain of visual acuity as compared to the other 4 weekly arms. And if you look at the central retina thickness, you can see the graph below, and you can see a little bit of zigzag which is seen. That means fluctuation of CRT was seen in the 8 weekly treatment, but visual acuity did not falter, and this fluctuation became even less when we looked at the second year or the 96-week results. So here you can see that the visual acuity gains were comparable in all 4 groups, including the 8 weekly treatment arm, and this was seen at the end of 1 year and 2 years. And importantly, the number of injections came down. While in the first 3 arms, there were almost 12 injections in a year. In the last 8 weekly arm with Aflibercept, we had 7.5 in the first year, and in the last year, only at the end of 2 years, only 11 injections, which means actually 5 injections lesser than the monthly arms. So approximately 90% of the patients in View study could maintain the visual acuity at the end of 52 weeks, and 48% of the bi-weekly or of the 8 weekly arm also maintained quarterly doses, and they were able to maintain visual acuity even with a reduced number of injections. View 1 extension studies looked at this number of injections for almost 4 years, 212 weeks, and they saw that though it was a capped injection that every 12 weeks they should give the injection, at least the patient should receive it. The visual gains were good, and the number of injections did come down. So the visual gains, even at the end of 4 weeks, even with once an injection in 12 weeks, it was reasonable. So this gave us the confidence to go into a treat and extend kind of a proactive treatment regime for our patients with AMD, so that fewer injections can be achieved. The ALTAIR study looked at the difference in the 2-week extension and 4-week treat and extend study, and this also had almost large number of patients, 247. Here they did treat and extend at 2-week interval and treat and extend at 4-week interval, and they have seen that the visual acuity gain was good in both of them, and the number of injections were also reduced. They were shortened the treatment only if there is persistent fluid or there is a loss of visual acuity and few other criteria which I mentioned here. Note is that the minimum interval was still 8 weeks and maximum interval was 16 weeks here. So once, for the first time, we have used, the study has shown us that 16-week extension of the interval between 2 injections and what happens. So even at 16-week, you can see that both the arms, 2-week treat and extend as well as 4-week treat and extend, both of them had reasonable good vision, and almost 60% of the patients could achieve a 12-week interval between the injections, and 40 to 46% of the patients could achieve a 16-week interval. So we are now at a stage where we can extend the period of interval between 2 injections to up to 16 weeks. And with this adjustment of 16 weeks, almost 96% of the patients could be kept at this injection interval for the second year. So conclusions from the ALTAIR study was that intravitreal Aflibercept injection was able to increase the treat and extend period to almost 16 weeks. This is a study which has recently been published in May 2022. So they did a sub-analysis of patients of ALTAIR study. Out of the 247 patients which were included in this study, 90 patients were of PCV. And we all know that PCV can have a very aggressive course, but amazingly, if you see the results, they found that almost 90 to 91% of the patients who had PCV could also be extended, and they could be kept at a 16-week interval, almost in 51. Half the patients of PCV enrolled in the ALTAIR study were at 16-week treat and extend. The next study was the ARIES study, and here also they compared the early treat and extend with late treat and extend, but both of them were found to be equally good. Number of injections were more or less the same. After these randomized clinical trials, there were a lot of real-world scenarios, like this study from Moorfields Hospital. They studied the treat and extend for 3 years, and for me, the most important thing was that 90% of the patients could be maintained. 27% of the patients did not need a repeat of injection in the year 3. So if we do a proactive treatment, we can actually in a position at some point of time in some percentage of patients to taper them off. Not only for the patient, but for the caregiver, you can see that the number of visits are much lesser, and so the productivity loss is also much lesser. Because of these RCTs and the real-world data, a lot of meta-analysis has been done, which has included only RCTs and observational studies, and they found that this was extremely possible to have the TNE regimen, which was more useful and led to better preservation of vision and reduced the number of injections. So this is another one. This is from multi-center study in Japan. Almost 50% of these patients, 97 enrolled, had PCV. So this study gives us a comparison between PCV patients and neovascular AMD patients. And you see here also similar has been seen that with treat and extend, number of patients of PCV who could be maintained at 12-week interval is actually 67%, which is more than 51%, which can be seen with neovascular AMD. And they also needed fewer injections over a 2-year period. So what we had initial concept that PCV will need PDT, it with Aflibercept monotherapy also, and with treat and extend, we are able to achieve these results. Another very interesting study is to look at polyp regression. So we know as long as the polyps are active, you will have recurrences in PCV. So polyp regression was seen at the end of 3 months with intravitreal aflibercept in 50% of the eyes, and in 40% of the patients who were able to be 16-week interval at the year of 2 years. And the importance of polyp regression, they say, was that the recurrences were much lesser, total number of injections were much lesser, and the mean treatment interval was significantly higher if you were able to achieve polyp regression. So with this RCT, with this real-world data, consensus and guidelines for treatment have emerged from Taiwan for neovascular AMD, and they have said that 3 monthly injections must be given. Treatment should after that be on a treat and extend. You can use a 2-weekly treat and extend or a 4-weekly treat and extend. 16-week interval is permitted and was seen in most of the studies. And they have said that after 2 or 3 consecutive 16-week intervals, if the eye remains dry, you can consider exiting anti-VEGF treatment. Similar consensus recommendations from Asia Pacific Vitreoretina Society, they have said that 3 consecutive injections must be done for PCV eyes. After that, they go into a 2 or 4 weekly treat and extend regime. And then they have mentioned that if you are using ranibizumab, the recommendation is that the treat and extend should be capped at 12 weeks. But with aflibercept, they have allowed the treat and extend to be capped at 16-week interval because that is what has been found to be efficacious. So just leaving you with a couple of examples. This is a type 1 patient which I have been treating. Vision was 6/6, and over a period of time with multiple and intravitreal injections of aflibercept on a treat and extend regime, the patient has been able to keep 6/6 vision in the last 4 or 5 years. This is an example. You can see the left eye had a large scar. It's a single-eyed patient, and it is 81-year-old, and we know increased age is a poor prognostic factor. This eye also had 6/6 vision, but after a monthly loading dose, patient has maintained 6/6. This is 2017. This is 2018. This is 2019. And you can see, though the patient had a little drop due to the COVID, but we were able to bring her back, and she still maintains 6/6 vision at the last follow-up in 2022. Thank you.